Clinical Judgment, Week 9. Today we have a client who's an 80-year-old female with coronary artery disease and hypertension who lives alone. Her daughter brought her into the emergency department. And this is what your assessment shows. The client is suffering from weakness, has a blood pressure of 115/68, confusion. She was found wandering in the neighborhood, unable to find her house. Her lungs are clear to auscultation. The daughter reports her mother takes a water pill 2 to 3 times a day. The client's temperature is 97.4 oral. Her respiratory rate is 24. She takes hydrochlorothiazide 50 milligrams. She's supposed to take 1 tablet a day. She lives alone, which means that she's probably pretty alert and pretty cognizant the majority of the time. Her heart rate is 118 per minute. She has dry skin, and she has active bowel sounds ×4. So what findings are going to be relevant or most important in this client's case? Okay, so this client is suffering from weakness. Excuse me. We know that weakness could be caused from being malnourished. Maybe it's just a disease process or fluid volume deficit. It could be hypotension. It could be caused from an infection or an illness. She also has confusion, which we know this is a change in the level of consciousness because normally she lives alone. And if she lives alone, she has to be pretty cognizant the majority of the time in order to be able to stay at home safely. So things that could cause confusion might be her medication. Maybe she's on something new. We know that infection in the older adult often is exhibited by confusion. It could be another illness or delirium or dementia or dehydration. She was also found wandering in the neighborhood, unable to find her house. And of course, this is caused by confusion, potentially delirium or dementia. Her daughter reports that her mother takes a water pill 2 to 3 times a day. This means that she most likely has a history of water retention. A very probable cause might be congestive heart failure. She has a respiratory rate of 24 breaths per minute. This could be caused by a fluid volume imbalance, such as dehydration or overhydration. Maybe she's suffering from hypoxia or poor perfusion, or she has a respiratory infection or a respiratory illness. Maybe she just overexerted herself. She takes hydrochlorothiazide 50 milligrams 1 a day, but her daughter reports that she's taking 2 to 3 times that a day, knowing that hydrochlorothiazide is a diuretic, and if she's taking 2 to 3 times the prescribed amount, then she could very well be dehydrated. The client has a heart rate of 118 beats per minute. We know this could also be caused by a fluid volume imbalance, whether it's dehydration or overhydration. It could be caused by hypoxia, a respiratory illness, a respiratory infection, or other type of infection. It could also be caused by some cardiac issues, such as a history of hypertension or potentially atherosclerosis or arteriosclerosis. And she has dry skin. Dry skin, this could be something that she just normally has. It may be due to poor hydration. She may have a process such as dermatitis or eczema. So weakness. Complications of weakness might be immobility complications. It may also be a safety risk and risk for injury. Confusion, we have a risk for injury. Wandering in the neighborhood, again, another safety risk. That increased amount of her water pill, dehydration and electrolyte imbalances. Elevated heart rate or respiratory rate could be caused by or lead to respiratory alkalosis and could potentially lead to respiratory failure. If she takes her hydrochlorothiazide, her diuretic as prescribed, there's really no complication. As far as the elevated heart rate, she has decreased cardiac output potential, and she has a risk for heart failure. And with dry skin, there's always a risk for skin impairment. So what do we think is going on with this client? Well, hopefully it's pretty apparent that she's probably suffering from dehydration due to taking too many diuretics. So what is her priorities? What do we need to focus on? Because if we do not focus on this, then it could potentially cause some life-threatening or life-ending issues. Well, we definitely need to focus on that elevated respiratory and heart rate. Those are too high. We also need to focus on that fluid volume deficit. If we correct that, it probably will correct her respiratory and heart rate, as will correcting the electrolyte imbalance. So we would expect her heart rate and respiratory rate to be within normal limits after we treat her. We would expect her fluid volume and electrolyte status to be equalized, and we would expect there to be no falls or injuries. So, is there anything that we should not do? Well, we definitely would not continue giving her her diuretic 2 to 3 times a day. She has to have that fluid volume replaced. So, what are we going to do for her? Well, because of her age, we need to especially monitor that fluid volume status with fluid replacement. You know, with the older adult, remember that they're especially prone to complications with fluid replacement due to their inability to adjust quickly to changes in the fluid volume status. So we need to monitor her lungs and her labs for certain. We also need to monitor her vital signs, her weight, and her level of consciousness. We should also monitor her heart rhythm because with dehydration, we could have some potentially lethal changes in her potassium level. We should always reorient her as needed. Apply lotions to the skin to help with that dry skin. We probably are going to do some lab work such as CBC and electrolytes. We would replace fluids either orally or intravenously. For safety measures, we need to keep her close to the nurse's station and frequently assist her with her basic needs. We need to keep eyes on her frequently. She should be up with assist because of the weakness. And we need to educate her on medications once she's cognizant. And we also need to evaluate the need for someone to come in and set up her medications. If she is not taking them per prescription order, that could be an issue. So prioritization, what do we do first? Well, we definitely need to, first of all, we're going to be looking at what we prioritized, but we definitely need to be monitoring her vital signs and her heart rhythm to make sure her heart rate and respiratory rate are within normal limits. We definitely need to replace fluids, oral and IV, get that lab work and monitor the heart rhythm once again. And as far as safety issues, we need to reorient her, complete those safety measures up with assistance, and educate on medications and evaluate. So, what do you think we should do first? We've just mentioned all of the interventions for each one of these priority issues. What should we do first? I would say that we need to get those fluids started. And in the meantime, we're monitoring her vital signs, her level of consciousness, and her heart rhythm. Get that lab work as soon as we get the fluids started. And maybe we can do that at the same time as we place the IV. We can also be drawing blood work. So again, evaluation. Did the client meet the expected outcomes with the treatment that we've done? With those interventions, are they appropriate? Did they achieve those outcomes? If not, what do we need to change? What will make a difference? So now let's look at our priority client. Which one should we see first? We have a client who had a syncopal episode prior to admission. We have a client with oliguria, a temp of 101.9, hot, dry skin, and a change in the level of consciousness. We have a client with oliguria and profuse diaphoresis after mowing the lawn. And we have a client with nausea and vomiting times 3 episodes. Well, let's look at each one of these. Let's start with number 4. Client with nausea, vomiting times 3. Well, yeah, we need to address that. Chances are we're not in life-threatening situation at this point, only after 3 episodes. So they can probably wait just a little bit. The client with oliguria and profuse diaphoresis after mowing the lawn. Well, generally when we mow the lawn, it's pretty warm outside. So we would expect the diaphoresis, and because of that diaphoresis, the client is not going to be urinating because they're in survival mode. They're holding on to the urine because of the loss of fluids through sweating. We have a client with oliguria, an elevated temp. Well, we know elevated temp, we could be losing fluids. So, of course, the client is going to be slowing down on the amount of urine. And the skin is hot and dry. So we need to keep that urine to help as a temperature control. And we have a change in level of consciousness. That one is kind of a priority, that change in the level of consciousness. And we have a client who had a syncopal episode prior to admission. Well, if it was prior to admission, we don't know all of the circumstances. We don't really know what's going on. Yes, we could consider that to be a change in the level of consciousness, but if it was just one time, it was just a brief episode, probably not the emergent situation, but I would consider it to be urgent. So priority client number 2, due to that known change in level of consciousness, oliguria, elevated temp. Okay, so NCLEX style questions. The nurse is working in a long-term care facility where there are numerous clients who are immobile and at risk for dehydration. Which task is best to delegate to the unlicensed assistive personnel? Instead of asking what UAPs can do, sometimes it's simpler to ask what they cannot do. Again, remember, they cannot evaluate, they cannot treat, they cannot administer medications, they cannot assess, they cannot plan the care. So let's look at our potential responses. Can the UAP offer clients a choice of fluids every hour? Can the UAP check clients at the beginning of the shift to see who is thirsty? Can the UAP give the clients extra fluids around medication time? Can the UAP evaluate the oral intake and urinary output? Well, I know that number 2 sounds kind of, yes, they can do that, but actually that is assessment. So kind of a fine line there. But offering clients a choice of fluids every hour, yeah, they can do that. The nurse is assessing a client and notes a bounding pulse quality, neck vein distension when supine, the presence of crackles in the lungs, and increasing peripheral edema. What fluid disorder do these findings reflect? So this question is basically asking, are these symptoms of fluid volume deficit or fluid volume overload? I don't know about you, but I think it's going to be fluid volume excess. We have that bounding pulse, neck vein distension, presence of crackles in the lungs, peripheral edema, too much fluid. The UAP informs the nurse that a client with hypernatremia, who was initially confused and disoriented on admission to the hospital, is now trying to pull out the IV access and indwelling urinary catheter. What is the nurse's first action? Remember, this would be a priority question that we're asking first. Most important, highest priority, best. So if we don't do what intervention, our client could have serious complications. Would it be placing bilateral soft wrist restraints? If we don't do that, is our client going to have severe complications? Informing the provider of the client's change in behavior and then obtain an order for restraints. If we don't do that, would our client have serious complications? Assess our client. If we don't assess, will our client have severe complications? Or offer the client oral fluids. If we don't offer them oral fluids, will they have severe complications? Well, for 1 and 2, we know that restraints are going to be the last option. We do not do that until we have exhausted all other options. Excuse me, such as toileting, giving fluids, giving them something to eat, treating pain, etc. But if we do not assess our client, there could be something serious going on there. And if we do not assess our client, then we could miss something very important. Always, if we have a change in status, then we have to reassess. Granted, the client was confused and disoriented, but now they're starting to try to pull out the IV access and indwelling urinary catheter. So we need to do a quick reassessment. This question, the nurse is asking for a psychiatric patient who is caring for a psychiatric patient who is continuously drinking water. The nurse monitors for which complication related to potential hyponatremia. And basically, what are the symptoms of hyponatremia and what are some of the more serious symptoms? Is it proteinuria and prerenal failure? Is it changes in mental status and increased intracranial pressure? Is it pitting edema or circulatory failure? Or is it possible occult blood and gastrointestinal bleeding in the stool? Complications of hyponatremia, number 2. The nurse is caring for a client with severe hypercalcemia. What safety measures does the nurse put in place for this client? Select all that apply. So basically, the question is asking what happens if we have high levels of calcium in the blood. Because remember, hypercalcemia, we're testing the blood, so we have high levels in the blood. Is it encourage the client to use a cane when ambulating? Well, not necessarily. They may not have issues with ambulation. Would it be encourage the client to call for assistance to get out of bed? Yes, we need to do that. That is a definite safety issue. Would we obtain an order for Ambien to ensure the client sleeps at night? Providing a medication to help the client sleep does not necessarily make for a safe situation. It can actually increase confusion or cause confusion and create a safety risk. Would we place the client on a low bed? Yes, definitely. If the client does happen to get out of bed on their own, this is a definite safety risk if their bed is elevated. Would we ensure that the top side rails are up when the client is in bed? This also can be a safety issue, just because it gives the client something to help reposition, but it also will provide some safety measure by helping prevent them from rolling out of the bed. And raising all 4 side rails, that's a restraint. So correct answers 2, 4, and 5. Last question. Clients with which conditions are at greatest risk for deficient fluid volume? Be aware that this question is probably asking what can cause fluid volume deficit. Would it be a fever of 103? Yes, client can lose up to 10% of their body fluid with each degree above normal. Extensive burns. Yes, they will lose a lot of fluid. Thyroid crises. Yes, we have increased metabolism. Their body temperature is going to be elevated. Again, metabolism is elevated. They are going through a lot of water. Water intoxication? No, that's too much fluid. Continuous fistula drainage. Yes, we're losing fluid from a wound. Diabetes insipidus. Most definitely.